I'm Kara Negri, and this video we are going to be going over the entire Edinburgh Visual Gait Score. This is the most requested topic because the Edinburgh Visual Gait Score is a quite thorough score that you can conduct on gait analysis in order to provide an outcome measure. So this video is assuming that you've already taken your videos in the coronal and sagittal planes, and we're going to be using the web-based software to analyze the videos. Okay, so we'll go ahead and get started by logging in. And again, if you've used the apps in order to get your videos up into the web, then your videos will already be in there and you don't need to worry about it. I would say refer to our other video tutorials on how to get your videos up into the web-based software. So we'll go ahead and log in. And P&O Data is a web-based service that you as a facility would buy a zone, and that would allow you and 10 of your other colleagues to converse over videos as well as conduct gait scores. So I'll go ahead and click on Kara's demo zone. You can learn all about these things in the Getting Started, which will go through some online learning modules that will teach you all about P&O Data. So we'll go ahead and log into Kara's demo zone. And as you see here, we do have some other online learning modules, but we're going to click on P&O Gait Scores. The one with the W next to it indicates that it's a wizard, and a wizard is a report template. So you're going to actually be able to load in several different videos over the length of time, and that will allow you to create a report based on those. So you get to do it over and over again is the idea. So we're going to click Edinburgh Visual Gait Score, Sagittal and Coronal videos. So these videos have been taken separately. If you're using anything else that's combining the videos, then we can go over that at a later time. But we're going to assume that you have two separate videos for this tutorial. So I'm going to create a new report. As you can see here, I can put a title into my report. So let's just name this Edinburgh Webinar. And we've got my name as the practitioner here. You can use the drop-down menu to find other practitioners. And you've got maybe a patient list here too. So we're going to use I'm a tester. And we'll go ahead and click Create. That starts our gait score wizard. Now there's a few instructions here. We do have a send analyst service, so if you want to send the videos to our team in order for us to conduct the score for you, you just would do the first 4 pages where you load your videos and tell us a little bit about the case, and we'll actually return the score for you, and you can make some adjustments and add your own comments in there as needed. So if you ever need any help, the PDF here in the corner is an online module that will teach you about the different pieces of the score and how to properly conduct them. But the whole point of the wizard is that it will lead you through step by step so that you don't miss anything with observational gait analysis, and you can have a very thorough report. Okay, so the first slide is to identify which of the segments of interest. And this, again, if you're using the Send Analyst service, is really important to clue us in on what we're looking at for this report. So I'll go ahead and hit knee, lower leg, ankle, and foot. And then any additional notes might be, if patient is experiencing instability. The next slide is going to ask us to note the side of the analysis. Sometimes if you have very complicated cases, you may actually have to do an Edinburgh Visual Gait Score on both the left and the right. So for this case, we want to make sure that we identify which one we're going to be using. So here we will say we're doing a right side and no device. Okay. If there is a device, you just might want to put the name of the device or a description of the device, because you can actually compare your interventions with this score. So going back and talking a little bit about the assessment tool, when you do receive a report at the end, there is a description of the assessment tool on the report. And I'll just go ahead and read what that description says. It is a validated assessment system which demonstrates change in walking ability over time. The observer uses the video analysis tools to score the patient's gait deviations from normal. Scoring uses a 3-point ordinal scale. So 0 is meaning normal, and that means that the patient falls between the mean, the normal, and plus and minus 1.5 standard deviations. And then if they get a score of 1 for each score, then that means that they have a moderate deviation, which means that they lie between 1.5 to 4.5 standard deviations. And a score of 2 for a measure would be a marked deviation, which would be greater than 4.5 standard deviations from mean. So the maximum total score per limb is 17 observations. And because we have the ability to score each at 2, then the theoretical highest score would be 34. So we're going to go through 17 different measures. We can rate them from either 0 to 2. So that means that we get 34. Now, let's say for this case we have no device, and then we're going to actually plan our device based on our video gait assessment, and then we can put our interventions into practice, and then we could actually measure again and show a reduction in gait deviations. So that is kind of the way to use the score. The other way is to use the score for that assessment piece, to identify which things you think you can address with your intervention, whether it be therapy or with a device. Okay, so the next slide is to select your movies. So again, you've already taken your movies, whether by iPad or a video camera, and you've gotten them into the web-based software. So we'll go ahead and browse and find those. So I'm going to load my sagittal plane video and then my coronal plane video. Okay, and then I hit OK. So the great thing about the score is that it's actually going to load the video that is of interest to whatever score you're conducting at the time. So as we move on, you see that we're first looking at initial contact in stance. And so the video analysis tools are here, and it pulls up the video of the sagittal plane so that we can look at the initial contact. I would just like to make a disclaimer about this video. They do pan the video camera in this example because I don't have as many examples of people walking that are not my own videos. This is one that I found freely available, and so it is not the most perfect video to be using for this score, but it'll do for the example. Really quickly, to talk about best practices of video, you want to keep the video stationary. You want to be about 3 meters away from the patient in the sagittal plane. You want to try to get 3 to 5 steps, and most of your angle measurements or any type of length measurements should be concentrated on the middle of the screen. So I'll go through that in a different tutorial as well. Okay, so as you can see, the score leads you through what you're looking for. So initial contact and stance, we're looking for the heel, if the heel contacts first, or if it is a flat foot contact, or if it's toe contact. So we'll go ahead and watch the video. And again, we're doing right side analysis, so let's make sure that we stick to that the entire time. And here we see that she does in fact have heel contact on the right side. So we'll go ahead and pick heel contact. And if we want, we can draw an arrow and point at that and capture the image. So every score, you're going to want to capture an image that shows why you chose that choice of the score. And then we can go ahead and mark some notes here if we'd like to. If you have more time, which I don't want to take up too much time in this webinar, but if you have more time, you can put, increased dorsiflexion, and we'll see, oops, I'm not in there. Yeah, there we go. So we can actually start to look at a few slides before and after as well. So we can see that, yes, she's in increased dorsiflexion, and then she actually has a rapid plantar flexion. So we can just make note of that. And if we had time as well, when you're doing these reports on your own, you might even talk about what that means to the patient. So this is going to disrupt her heel rocker. So I just want to give some examples of how you could use this to really justify or show why you're making these clinical decisions. And if you have something that you think you can do to address this issue, then you can do that as well. So it's going to disrupt her heel rocker, her forward progression, and shock absorption. Now that's a very thorough report, but just an example for you guys to think about. Okay, so we've put some notes in, we've made our decision, and we've taken our screenshot, and that's what you want to do for each of the slides. So we'll go ahead and go to heel lift and stance. So normal heel lift and stance occurs at terminal swing, or terminal stance, I'm sorry. So we're gonna go ahead and progress the video forward. I like to use my forward and backwards buttons on my keyboard, and that helps me to go frame by frame. So I'll just go ahead and go forward, and okay, so we see that we have initial contact on the contralateral side, and there's no heel lift yet. So we're gonna say that this is delayed heel lift. Obviously, if there's no forefoot contact because they're avoiding the forefoot, then that would be why we would choose this one. If it's normal, it means that they get slight heel lift in terminal stance before the contralateral limb contacts the floor. If it's early, that would be something more like a vaulting, or because maybe someone has a plantar flexion contracture. And if there's no heel contact, so if we have idiopathic toe walking or toe walking in general, then you would score that. So let's just see for an example, if we had no heel contact, that would actually be a deviation of 2 points. So, and that's something that we know that we can address with an orthotic intervention. So for her, we're just going to put delayed. And we will circle that her foot is still on the floor. And we'll just make a comment about her leading limb is in initial contact and no heel lift. So we know from gait analysis that heel lift should occur in terminal stance, and it is a single limb support phase, so we should be seeing some heel lift there. And we'll go ahead and capture that as an image, and we'll progress forward. Okay, so now we have maximum ankle dorsiflexion. So this is something that we are going to be looking at in terminal stance pre-swing. You want to reference the foot on its own, not in reference to the floor. So if they do have toe walking, you're just going to look at the angle of the foot, not in reference to the floor. So here we want to go through frame by frame and see where she has maximum ankle dorsiflexion, and we can actually use the angle tools if we want to compare those, but it looks as though here she's got her maximum ankle dorsiflexion. And you can just see here with the tools, I'm picking a different color just to make it stand out a little bit differently, and I'm actually going to choose a line that's not so heavy because she's a small little child. So okay, so we will go ahead and quickly do that math. So that's 90 degrees minus 63, and that would equal 27. So that would be in the increased dorsiflexion. So we'll go ahead and capture that image, and we'll move forward. Okay, so hindfoot varus and valgus, the video analysis tools will actually pull up your coronal video for you. So we'll go ahead and scrub the video so that we can go ahead and see the rear view. Now, just something to keep in mind here, once in a while when you're doing these, you may get turned around when you switch from sagittal to coronal, so just really make sure that you're sticking with the right side analysis for this and you don't switch to the left all of a sudden. So here we are, and we can go ahead and start our video. We can play, and this is a little far away, but we can see this. She does look like she gets a little bit of valgus with that stance phase. So we will go ahead and just take an image here to show that. And that looks like it is moderate valgus. So we will capture that as an image, and we will just make a note of instability at the ankle, and we will progress forward. All right. Okay, so going forward to foot rotation and stance, I actually contacted the author of the score because in the actual literature for this score it says SI, more external than KPI, so here. But actually that was just a mistake from the font change of the publication, and it meant to be SL. So that just means slightly more external than your knee progression angle. So it's not as a difficult score as you may have assumed, or that always confused me, by the way, so that's why I contacted her. Okay, so again, we're going to be looking at the right side, so making sure that we don't get turned around too much. And we'll go ahead and take a look at where the foot is in rotation. And she looks as though she is pretty straightforward. And so it's about 0 to 20 degrees externally rotated. So we'll just go ahead and click that. And we can draw an arrow, but that might not add to the observation much. So we'll just go ahead and click capture. And no visible rotation, and we'll go ahead and progress forward. Okay, so the next score is foot clearance and swing. So we want to make sure that the whole foot is clearing the floor, and we look through her swing phase, and she does look like she is clearing the floor. Now she may be going through a little bit of excessive dorsiflexion in order to do that. So you've got a few options here. The first being high steps, meaning if they're using any type of hip hiking, or maybe the excessive dorsiflexion, excessive knee flexion in order to clear the floor. Now full means that they do have full clearance, so she does have full clearance. That means that they don't get any points for that. They're good. Reduced means that if they have any type of contact during swing phase, and none would mean that they're dragging some portion of the foot at every single period during the swing phase. So we can just take a nice image here, show that she's got some clearance under her foot, and put that into place. We can maybe just write that she does have some increased dorsiflexion. Oops, spell that right. Okay, moving on to maximum ankle dorsiflexion and swing. So we want to go through and look for that maximum angle of dorsiflexion. So in this score, we're looking for normal dorsiflexion up to 15 degrees or 5 degrees of plantar flexion. So it's a pretty wide range there. And we can go ahead and take an angle measurement, here, pick our angle tool, and then click here and click there. So she's got 30 degrees of dorsiflexion, so that's increased dorsiflexion. And we'll just take an image there, and we'll mark that. So 90 minus 60 equals 30. And what this effect is that it's going to actually poorly position the foot for initial contact. So that's really what we're concerned about, which may cause some instability. All right, knee progression angle in mid-stance. We're looking to see if the kneecap is visible during stance phase. So we've got options of external, so whether, you know, their knee is pointing externally, but the kneecap is partially visible or completely visible, or not at all. So if we progress through here, we'll just look at her knee progression angle. Again, we're doing the right side, so it looks as though her kneecap is visible the entire time. Now, I just want to note that if there's anything that you can't see in the videos, or the angle tools aren't really helping your observation, this is meant to be a score that can be used just based on observational analysis. So you want to, you know, you don't have to depend on the tools the entire time. You can make your own clinical justification based on your observations of being in the room in conjunction with the video analysis tools. So we're going to say here that she's pretty neutral and that her kneecap is midline. And we'll just go ahead and capture a screenshot. We could add a line here just showing that. If you ever capture a screenshot and then you want to capture another one, you just go ahead and click on the screenshot button again, and it will replace your video. So if you want to see the shot that you captured, you just hover over it, and it will bring you to that shot. All right. So we can say that she's got a pretty neutral. Or, you know, some might say that it might be internal. This will be up to you as a clinician, but we'll just say it's maybe slightly, but not significant. Okay, so next we're going to move on to the knee. So we first address the ankle, then we're going to address the knee, and then the hips, and then the trunk. So the knee should approach full extension in terminal stance. So we'll go ahead and look, and she looks as though she's got a little bit of flexion. So we'll just look at terminal stance, or knee progression in terminal stance. Let's go to stance, not swing. So right before she lifts her foot off the floor, we want to see what position her knee is in, and we can take an angle measurement there. And if you ever, I don't really like having the large angle, so what I do is I actually will start at the other segment, so starting at her ankle, going to her knee, and going up to her hip. Another thing to note is that there are markers on her. The studies of these scores show that you do not need markers. You do get better repeatability or validity and observer inter-rater reliability, but you don't have to have markers. People are still reliable without the markers. So you just really need to consider, you know, how much time it's taking out of your day to do this observational gait analysis. You know, quickly taking a video, being able to go back and do the analysis after the patient has already left is quite quick, actually. You can get down to about 15 minutes to do one of these analyses. But if you add markers, then that's going to add, you know, quite a bit of time to the process. And the other thing I don't like about markers is sometimes if you're in a rush and you don't place them exactly correct, then you're relying on the markers when they weren't placed correctly in the first place. So, you know, you are a clinician, you have a very good eye for joint centers, so, you know, go ahead and disregard the markers and use your clinical judgment. Again, if you can't see the observation well enough, like if the patient is wearing pants or something, then you use your clinical judgment based on what you saw during the session. Okay, here we're starting from 180 and going to 163 would be 17 degrees, and so that is moderate flexion. Okay. So we'll go ahead and capture that as a screenshot, and that will be added to our report. All right, so now we're looking at terminal swing. So we can go ahead and progress forward, and we see right before she contacts the ground, we'll take a look at what her knee position is. And we can take a measurement there. Again, it's a larger angle, but we'll go ahead and go with it for the sake of time. And you know, it actually is easier to do the math. So it's 18 degrees of knee flexion. And really what this is doing for the patient is it's resulting in a shortened step length, and she may be unable to fully extend. So we'll just go ahead and write that down. All right, and then we'll go ahead and pick moderate flexion as our choice, and we see that she gets 1 point for that deviation. Okay, so peak knee flexion in swing. This is important for swing phase clearance. So we want to go back and see how much she can bend her knee during initial swing phase. So normally in pre-swing we see about 40 degrees of knee flexion, and then in initial swing we see about 60 degrees of knee flexion. Here we've got a range of 50 to 70 degrees for normal. So we want to take an angle measurement here and connect and we see 151. Another way that you can do this measurement to get your math a little bit faster is to take your line and, you know, imagine yourself drawing through the thigh section and then going to the ankle. So that would be 28 degrees. So we can mark here, take that angle measurement, and we do have severely reduced knee flexion in swing phase. And what that is going to do is interfere with swing phase clearance. And as we saw in the previous swing phase clearance score, we saw that she does have excessive dorsiflexion, and that's probably in conjunction with the fact that she has reduced knee flexion. So we'll go ahead and move on. So now we're going to go to the hip. Now the hip, we're looking for the peak hip extension and stance. Normal gait, we do see the peak hip extension and stance in terminal stance and pre-swing. So we'll just go ahead and look observationally. She looks like she's still a little flexed here, and then she's extending, and then she's still extending a little bit before she starts to flex. So we'll go ahead and go back to that maximum angle. Now, if you see here, you can actually click to enlarge these images, and that shows you that you can use an angle measurement, kind of like I just did with the knee, so that you can get your math a little bit faster. One thing I want to note with this, though, is that you don't want to use the angle measurement tool that keeps perpendicular to the floor. So if you use that, you're not taking into consideration her trunk flexion. So since she is sort of bending at the trunk a little bit here, she's leaning forward, we wouldn't get a proper angle. So we don't want to use that tool, because if you can see here, we would be doing this, and that would give us we would be doing this, and that would give us her 13 degrees of hip extension. But we want to use this tool instead, and maybe we'll pick a different color since we're going on top of her shorts. We'll pick blue, and we want to think about drawing a straight line through her trunk and matching that with her thigh section. Okay, so we actually get about 11 degrees, and that is within the normal range of hip extension. So we'll just go ahead and say that that's within normal limits. Okay, so maximum peak hip flexion during swing, we'll look for this in terminal swing. And she starts to rotate a little bit here. So let's say that just pure peak hip flexion would be right around here before she starts to rotate her pelvis. And we can even write that down, is that pelvic rotation, helping achieve step length. Okay. And we'll do the same thing that we did before, where we're going to take into consideration her hip or her trunk flexion, and we will take that angle there, which is 39 degrees of hip flexion, which falls in the normal range as well. So we'll go ahead and capture that as an image. Now we're looking at pelvic obliquity at mid-stance. So up and down in this measure are referring to the stance side. So if you are picking marked down, so it's greater than 10 degrees, that would mean that her stance side pelvis is dipping more than 10 degrees down based on, in relation to her swing phase side. So again, we're looking at the right side here, and we want to go at stance, mid-stance. She doesn't look like she has a lot of issues here, but we can go ahead and draw a straight line just to have that help us. And I will actually change the color here to a red line and change the weight as well. So we can kind of see her ASIS here and here. And she may be slightly down on that swing phase. But we have 5 degrees of that, standard deviation. So I'm going to go ahead and pick normal obliquity. We've all seen, cases where there's definitely more. Now you can use an angle measurement here, but it's just up to you. So here I'll just again put within normal limits. Okay. So now we're looking at the pelvis during mid-stance as well. So we did see some pelvic rotation, but what we're looking for is any type of backward or forward rotation of the pelvis. So let's go back to mid-stance for her. And her arm is kind of in the way, but I would say that she has a little bit of a tilted pelvis forward. But we do have up to 10 degrees for forward rotation. So I'm going to actually pick normal for this one. Now, you can go ahead and look and use your judgment. The angle measurements are there to help, but it's a difficult one to make a judgment on based on the angle measurements tools that we have here. So you could start to use those if you think they help. But I find that a tool just like a line tool helps me just to see her pelvic rotation. So we can take a look at one pelvic side versus the other, which again I'm not really seeing much here. So we'll just go ahead and put within normal limits. And now we're to the trunk peak sagittal position and stance. She does have a little bit of forward rotation, and then you see a little bit of lordosis here in order for her to get a good step length. She kind of lordoses her back in order to do that. But you want to pay attention to the limits of this. So forward rotation more than 15 degrees, I don't think she has that. But this is where we could use that angle measurement tool that helps us look at something in relation to vertical. So we can go ahead and take a look at her trunk. In relation to vertical, we're getting 8 degrees. So she does have a moderate forward lean. So we'll go ahead and mark that. We do get 8 degrees. She does have that moderate forward lean. And last but not least, we're looking for maximum lateral shift. So the trunk should normally displace laterally about 25 millimeters towards the stance leg. So we'll see the options here are marked. So that would be that, they really side bend in order to, get their weight over onto the stance leg. or moderate, just a slight lean or normal, or reduced, and that means that the trunk remains over the swing leg, so they're not confident at all, or they're not able to shift their body weight. So we'll go ahead and look at her during stance phase. She looks pretty upright to me. We can go ahead and use an angle or a line tool just to take a look. And she's got pretty good, if anything, she is slightly reduced, but I would not say that it'd be more than 25 millimeters reduced. So she remains pretty upright. Okay. So now we're at the end of our report. You'll see the summary page. Again, if you did want to use the expert analysis for the videos, you wouldn't have had to do any of those. You would actually only do the first floor slides, which tell us about the body segments, and then loading the videos, and then you can skip ahead to this. If you ever want to go back through and look at anything, you click at that progress bar at the bottom, and you can actually go through and find what measure you had done before. So for instance here, we've got foot clearance and swing, so we can actually jump to that page if we wanted to review it. But we'll go ahead and finish our report, and you will see here that we get our report summary. We've got our assessment tool description here. We've got our body segments of interest and maybe any additional notes, a device description, and then we get into our imagery and our scores. So you see the score here for each section, and then we can see where exactly she's getting her gait deviations, and then we can use this to share. So we can print this and send it to another practitioner, a physician, an insurance company, whatever we would want to do. So you can see that the final score that we have in the upper corner here is 10 out of 34. And then, like I said, you may want to go through and do an intervention and then redo the score several weeks later, and then that way you can show what your intervention has done to help that person achieve better mobility. So if you ever need anything or have any questions about how to conduct a gait score report, please contact me, Kara, at P&O Data Solutions. So you can check out the website, pnodata.com, and my email address is Kara, C-A-R-A, at pnodata.com. Thank you, everybody.